about microskills for clinical teaching. As always, I have no disclosures and just one objective today, and that's to review the 5 essential microskills to improve bedside teaching. So why bother with this? It's a very practical approach to teaching. It's great when you're doing one-to-one teaching with the residents or the students. Very good when time is limited, which happens often. And it's based on those principles that we talked about last month with the principles of Ajachachi. So the brief overview is the resident's going to go and talk to the patient, come back, give a case presentation, including with an assessment and a plan. You are going to diagnose the learner and assess whether or not they can give you a commitment, which we have to start with, and probe for supporting evidence. And then finally, you're going to teach the general rules, the reinforcements, and correct. So we'll go into a little more specifics. The case presentation is what this initially hinges on. So probably the hardest part for all of us is that we have to be patient and listen first. You have to let the resident complete their case presentation. Now, if this is early on and they're struggling with the presentations, or you like a presentation in a certain way, the best thing to do is take them through what you expect. But once you take them through what you expect, let them do it. This is not the time to interrupt. This is not the time to rush them. Have them present the case as you want it presented, and then go on to the next steps. So number one, get a commitment. Don't let the resident wash. They come back with a difficulty breathing case. Ask them what's going on. What diagnosis do you think is it? Doesn't matter if they're right or wrong. You can see that this is clearly a CHF case, and they can tell you it's a COPD exacerbation. If that's their commitment, let them stick to it. This is not your time to change what they say, but rather have them die on a hill at that point. The questions that are not going to get you a commitment. Sounds like pneumonia, don't you think? Don't suggest what you think it is. Don't get them to have premature closure. Allow them to come up with their own commitment. Prompting them with things like anything else. Did you find out what came first? None of that's important. What you need is the commitment. How to get the commitment? What do you think is going on? Why do you think the patient's been non-compliant? What do you want to do next? What do you want to accomplish? These are all ways to get the commitment out of the resident and have them actually think about what they're talking about. Microskill 2 is probe for supporting evidence. Once they make the commitment, ask them how they came up with that idea, why they think that. Why do you think this is CHF? Why do you think this is COPD? Why do you think it's pneumonia? What things did you find that's going to let you come up with this? Don't dismiss them with an I disagree. Do you have any other ideas? Don't tell them what this is a classic case of. Don't ask for other information than what you're looking for at this point. None of this is going to help the resident learn or be taught at this point. Instead, ask them things like, what are the major findings that led to the conclusion? What else was considered? And why did you rule out the other things that aren't the thing that you committed to? Now, this is time for you to teach the general rules. Patients in heart failure and needs diuresis, don't start the beta blocker now. Not helpful. I'm convinced that diagnosed cellulitis, I don't even know what that means. You need aspiration from heart culture. But what is helpful is if the patient only has cellulitis, INDs are not possible. So if the resident suggested something like this, you're explaining why you're not draining it. What the symptoms of UTI usually look like, what the UA is going to look like with the UTI, secondary, tertiary findings as well. These are helpful approaches during this stage. Microskill 4, recognize, personalize, and be specific with what they did right. Not helpful to say you are right, that was good. Nice presentation. Rather, you did a very thorough job evaluating the patient's abdominal pain, identifying the combination of a positive Murphy sign and bedside ultrasound consistent with a dilated biliary tree was essential for the diagnosis of acute cholecystitis. You considered the patient's finances in your selection of drugs. Your sensitivity to cost will likely contribute to his compliance. Finally, the last microskill, correct the mistakes. things that aren't helpful. You did what? What were you thinking? What? Why? Instead, I agree that the patient is probably drug seeking, but we still need to do a careful history and physical exam before we make any recommendations. Build on what they said, gently correct. This will be more helpful for the resident's experience and your own. So this is also known as the 1-minute preceptor. And once you get comfortable with this technique, it's going to be very easy for you to summarize the case, get a commitment, probe the underlying understanding, reinforce what was done right, teach the general rules, and correct any errors. So before I ask if there are any questions, just a shameless plug. This Thursday is the GME Faculty Development Retreat. If you haven't had enough of me talking yet, I'll be speaking from 9:45 to 10:30. But before me, there's better speakers that'll give you a lot of information for GME faculty development. I know a lot of the faculty has signed up. This is open for anybody. This does have CME. So if you're looking for some CME, I hope to see you virtually there. So now I'll ask if there's any questions.
Any questions?